Great. So just to let everyone know, the meeting is being recorded. And yeah, so thank you so much for being here. We're the Irish Global Health Network and ESTHER Ireland, and we're so happy to see you here. I'm Manasvini. I'm an intern at IGHN and ESTHER Ireland, and I'll be starting off the event, and then we'll be joined by Brittney Mengistu, whose workshop will make the remaining block of the event. So we're very excited to see you here. Okay, so welcome to Decolonizing Global Health, an interactive introduction. Kelsey, you can go on to the next slide. So just to provide you an overview of what we'll be covering today, we'll be starting off with this brief introduction to the movement of decolonizing global health, and setting the stage for Brittney's wonderful workshop. We'll be first starting off with one activity, which is called Visualizing Positionality and Power, followed by a 10-minute break, followed by part 2 of the workshop, which we'll examine something called the Circle of Influence. And then we'll get into our key insights and wrap up. So this event, as I said earlier, is co-hosted by the Irish Global Health Network and ESTHER Ireland. Just a little bit about us. The Irish Global Health Network started in 2004 and has been bringing together people interested in health and development and reducing health inequities, with a particular commitment to people in low and middle income countries. And ESTHER Ireland is a HSC initiative that is hosted, has a secretariat in IGHN, and it is a collaboration that supports and fosters partnerships between Irish health institutions and counterparts in low and middle income countries. Health equity and equitable partnerships are the cornerstones of both IGHN and ESTHER. Keeping this in mind, we have been interested in learning more about decolonization, and we hope that this event is the first of many. So yeah, a little bit about who we are, who will be hosting you today. So Brittney, please introduce yourself.
Sure, thank you so much, Manas. My name is Brittney Mengistu. I'm a postdoctoral researcher and lecturer in global health. And I currently work and live in the Netherlands at Vrije University in Amsterdam. And in this position, I work on a number of projects related to social justice and health equity. For example, I'm involved in a project in Ethiopia and Indonesia and also in the United States. But I'm also a facilitator. So I work on these kinds of opportunities and webinars and processes to reflect on how we can become more self-aware in the work that we do and how to increase our impact, our social impact in the global health sphere. I'm also an African-American woman. My pronouns are she, her. And I'm also the wife to one husband and the mother of 2 daughters. And I'm very happy to be here with you today. Thank you, Manas.
Great, Brittney. We're so happy to have you here. Thank you so much for introducing yourself. As I said earlier, I'm Manasvini, or Manas, and I'm a communications and grant management intern with ESTHER and IGHN. I recently graduated with a master's in public health sciences from Karolinska Institute in Sweden. And during my time at KI, I was involved in a student-led group called Decolonising Global Health, where I engaged with and started advocating for DGH among students and staff. I'm very passionate about health equity, and I'm excited to share everything I've learned so far in my journey before we turn to Brittney's workshop. Okay, so before we really get started in understanding what decolonization is, a brief note on terminology. I'll be using the terms global south and global north, and these two terms refer to the distribution of wealth and power between specific areas of the world. The global south includes countries with a lower middle income background, mostly in the Southern Hemisphere, many of them are still navigating the aftermath of colonialism. And the global North refers to wealthy and powerful regions, predominantly located in the global North, with some exceptions, and many of these were the colonial powers. There are issues with this terminology. No terminology is perfect, but these terms are currently used predominantly in the field, so we'll be using them for now. Okay, great. So what is the Decolonizing Global Health movement? Decolonization has been a term for several years, but entered global health discourse with the start of the Roads Must Fall movement in the University of Cape Town. South Africa is, as a former colony, still has and had many artifacts of colonialism, especially in educational institutions. Cecil Rhodes was an imperialist whose statue was up on the University of Cape Town campus, and he had a huge role in colonizing South Africa and restricting the rights of Black Africans. So in 2015, students of the University of Cape Town and other universities demanded that the colonial history of these institutions be addressed and acknowledged. And this involved the renaming of buildings, removing statues, but also fundamentally changing the syllabus and how research is conducted. So this movement spread across many disciplines and reached global health. And now there are currently various groups advocating around the world for decolonizing global health. But as I said earlier, decolonization itself has been around for a long time. What is it? How can we define it? Decolonization is the process of revealing and dismantling colonialist power in all its forms. This includes dismantling the hidden aspects of these institutions and cultural forces that had maintained the colonialist power and that remain even after political independence. So this is to say that colonialism had lasting impacts on every facet of the world, including our economics, our politics, culture, language, and sciences. Therefore, the process of decolonization did not really end or stop with when countries gained political independence, but is an ongoing process. So colonialism has had a huge impact, as I said, on all facets of the world, including equity. Colonialism is strongly tied to economics and has shaped modern wealth and inequity in many different ways. So you can classify colonialism on many different types based on the economics. One of the types is settler colonialism, where a settler society invades and attempts to replace the original indigenous population with a new settler society. So examples of this include the United States, Canada, and Australia. And then extractive colonialism is when colonizers take control of natural resources and trade the export of goods in an exploitative manner. This includes the slave trade. So examples of this are the Democratic Republic of Congo and many other countries in Africa. The wealth of the global North was built on slavery and colonialism, and exploitation of the global South has been core to how economic inequity looks in the world now. You can see this in the debt patterns across the world. Low and middle income countries are at a record level of debt, especially since the pandemic, at over $860 billion. And at least 45 low and middle income countries are considered in or close to debt distress. And these patterns kind of reflect the colonial power structures. Many international financial institutions contribute to this inequity, along with global North powers, which continue to serve their own political and economic interests, and also shape the current state of global health. So global health itself has its roots in colonialism. It started off at a point where colonial administrations sought to protect their investments and to prevent the spread of infectious diseases. This was related to the needs of coloniality and to maintain trade and production rather than to provide healthcare as a basic human right, as much of global health now understands it. In this way, tropical medicine was the first iteration of global health, which is driven by Western imperialism. And medicine was used as a way to control and civilize people in many ways. And this ideology also became very closely intertwined with racist beliefs. You can see this in the emergence of race science and eugenics, trying to use scientific methods to prove superiority of certain cultures and civilizations over others. And you can see traces of this even now in the present with racist beliefs and dehumanizing beliefs, such as the disbelieving the pain of brown and black bodies. For instance, doctors in the US are 2 times more likely to underestimate the pain of Black patients as opposed to white patients. So these are all things that we can see are rooted in this colonial history of global health. The term global health came out about more recently in the 90s and aims to move away from the colonial roots of the discipline. And in this way, it has its goals in advocating for health for all people, wherever they may be from in the world. In this way, global health is associated with more concepts of unity and transdisciplinary action, which is very different from its history. However, as this quote really succinctly puts it from Mariam Fofana, despite its seemingly more inclusive appellation, the intellectual, financial, and political centers of global health remain firmly ensconced in the first world or global north in some ways. And it's important that we acknowledge this history and address it and see how it has shaped our present. So now we can see many of these same power structures in the ways that global health operates. How priorities in access and funding to aid are set, how parachute research is conducted, where researchers from a different culture, global north, will come in with kind of a savior perspective to work in low and middle income countries without knowing that context or giving power to the people in the local context. The paradigm and the core set literature and education and research that is chosen, the research tools and metrics we use, the language we use, hiring policies, conduct and publication practices, and the global powers that control and set the agenda of global health, such as intergovernmental organizations and high-income countries' governments. These are all remnants of this global colonial power structure. Another example of this that we can see, and many of you will be familiar with, is vaccine inequity, as we saw during the pandemic. Vaccines should be allocated equally across all countries, regardless of their developmental or economic status. But we know that that really wasn't the case. In November 2023, we see that 73% of people in high-income countries are vaccinated with at least 1 dose, compared to 36% in low and middle-income countries. And this is, very closely associated with this lack of access and affordability for vaccinations in low and middle-income countries. To vaccinate 70% of the population, high-income countries had to only increase 0.8% of their health funding, whereas low and middle-income countries had to increase more than 50%. These things happen due to vaccine nationalism, with countries going out of their way to hoard vaccinations for only their population, and also issues such as intellectual property rights, where these rights are valued more than the right to access to vaccination. So here again, you can see the practical impacts of the same power structures that we started off with in history. Another example that is very contemporary and relevant is the example of cobalt mining in the Democratic Republic of Congo. If you remember earlier, I said that this was DRC was an example of extractive colonialism, and you can kind of see those similar patterns even now. Cobalt mines in the DRC are very valuable because cobalt is essential to making rechargeable batteries, electrical vehicles, and phones, which, you know, in every electronic device that we own, cobalt is present. And 75% of the world's cobalt production occurs in the DRC in industrial and artisanal mines. These are mines where the working conditions are inhumane. There is a huge amount of child labor with families reliant on these children's income. And there is also a huge amount of environmental impact with water pollution and carbon dioxide and nitrogen emissions. And it's important that we see that even now the labor of people in low and middle income countries is exploited to serve products that are used by, and like in supply chains that are controlled by high income countries. But if we are to look at what global health stands for now, which is health, equity, and justice, we can't achieve that without addressing all these power structures that, you know, as we saw just now, have an impact even in the present world as it is. So colonialism cannot be kind of dismissed as a thing of the past and needs to be confronted now and addressed now to ensure that global health is able to live up to its new standards of health, equity, and justice. So what does it actually mean to decolonize global health? A truly decolonized world may not be something that we recognize or able to simply define. It will require the dismantling of how systems currently exist. And, you know, that's a very a work that requires a huge amount of creativity and imagination to see how we can create new structures that are not seeped in these power imbalances. But in the meantime, there are many, many small actions we can do to live up to the mission of global health, which involves dismantling our power structures wherever we see them, indigenization, that is replacing current very Western Eurocentric methodologies with more indigenous methodologies that suit local contexts, moving away from Eurocentrism, prioritizing and supporting local communities through localization, centering humans and health instead of capital, and removing individualism and competition from global health. There are many people who are doing great work in this field. Here are some examples of organizations that are making an effort towards more decolonized and equitable health systems and global health. So these are examples you can look into later. But now, I think after this whole introduction to the movement, it can be very overwhelming to hear all of this information. But it's important to go back, take a step back, and see what place you have in this. Where can you begin? And I think the first step is always reflecting and seeing where you fit in the system. Asking yourself questions such as, does true neutrality in research and practice of global health exist? Reflecting and understanding the role of current systems, being aware of the power imbalances and biases in your own actions, and learning and changing your ways of working and interacting. And this leads us very nicely to our workshop, which is led by Brittney. So take it away, Brittney.
Thank you, Manas. That was really helpful. And I think how I would transition to this big question is, how do we begin, right? So we begin with reflecting on who we are, but what does that mean? And what role do we play in this movement of decolonizing global health? So I think one place where we definitely should start as a collective is to reflect on our positionality. So what is positionality? It refers to our location or our social position in relation to the identities we occupy. So for example, that could be race or class or gender, ethnicity, for example. And it really is just who we are in relation to a specific social or political context. And in thinking about our positionality, we have to consider three considerations. Is what are we doing? So if you're a researcher, what is being researched? Can you go back to the previous slide? Yeah, thank you. What is being researched and what is the area of focus? If you're a practitioner or if you're a student, what is it that you're interested in global health? Who is being researched? So who is the population of interest? So for example, I mentioned earlier, I'm working with Ethiopians in Ethiopia. And so that would be a community that I'm working with. I'm working on a specific topic, but then also how is the research being conducted? So what are the methods that I'm using, or what is the process that I'm going to adopt to do this particular project? And why is that even important? Because who I am and my perspective on how things should be done influences the choices that I make. And so when we think about positionality in relation to those three considerations, we also have to consider what does positionality look like. So positionality can be fixed or culturally ascribed. Like I mentioned earlier, I identify as an African-American woman. Even if I had not said that, many of you probably would have racialized me as Black because maybe the texture of my hair or the color of my skin. And that's something that I cannot change and also do not want to change. Positionality can also be fluid and subjective. So like political views, for example, that can change over time, or maybe even religion, what religion I practice, that could change over time. I mentioned that I'm a wife and a mother. Those are identities that I didn't always have, that I kind of joined these social groups over time. And our identities are also intersectional. So with those of you familiar with intersectionality or intersectional theory, it references to experiences that we have at the intersection of two or more identities. So for example, the experiences that I have as a woman in a particular context, it's going to be magnified, for example, or my experiences are going to be unique at the intersection of kind of my race and my gender. So the experiences that I have as an African-American woman are going to be different than if I were in a situation where it's just my gender, where I'm having an interaction. So I'll give you an example to make it a little bit more clear. If I am in a women's only event or a conference, we're all women in this setting, right? We all identify as that. So my experiences in that setting is not going to be predicated on the fact that I have this shared identity. In that setting, what may be more salient or important or stand out to me may be my racial identity. If I'm maybe the only Black woman in the setting, or maybe I'm one of few. So that kind of shows how your identities may differ in certain contexts. But at the intersection of that, and this is what Kimberly Crenshaw mentioned when she coined this term intersectionality, is that in the legal system, African-American women at the intersection of race and gender experience more discrimination compared to men who were considered just African-American or white women, for example. So when we think about positionality, sometimes we think about it as separate identities, but it's important to recognize that some of these identities often overlap, but then they overlap in different ways for different people. And these are always in conversation, not only with each other, the identities you have, but also in relation to the context that you're in. And so many of you are wondering, why is this even important to decolonizing global health? Well, your identities really influence the way that you understand how the world works. If you are socialized to believe a certain way, you learned, certain ideologies growing up, for example, That influences the way that you see the world, how you make sense of things, and it also influences your interactions with others and your behavior. And that is what necessitates constant reflection. For example, children are not born, this is just an example, children are not born being racist, for example. This is something that they are taught at a young age, not they, all of them, but some children are grown, raised in a specific context where they are taught to learn and to think about people in a certain way, right? So some of our identities, of course, they are things that we may see in the mirror or maybe some views that we have, but some of this is learned behavior as well. And this is what requires our constant reflection. And so what does this have to do also with decolonizing global health? It's a relationship between positionality and power. So if we look at the wheel of power, the wheel of power and privilege, I like to use this diagram purely as an example. So this is not exhaustive, it does not apply to every context, but it gives you an idea of how how certain groups may experience power or marginalization differently. So the social identities that we occupy positions us within and against various power structures. So for example, in a certain context, you may experience more power, maybe if you speak English. If you have a certain accent when you speak English, you may have more opportunities available to you, or maybe if you're more fair-skinned, or if you have a certain citizenship, right? So we know, many of you may know about the inequities with traveling across borders from people from the global majority, and the privilege it comes with having a passport from the global north, for example. So that's a little bit of power that we have in our ability to even migrate across borders. And this is important because it allows us to reflect on the power that we have that are associated with our identity and our identities, and allows us to make different choices, right? So if we know that we have power because we are perceived a certain way, then we can be more mindful of the way that we interact with others. If we experience marginalization in a specific context, then we know there are certain options available to you as an individual in a specific context, how you would like to proceed, or if things can change, how they can change, and what you can do moving forward. But knowing this relationship between positionality and power allows us to think about our moral dilemmas, our ethical dilemmas in global health research and practice, and to really sit with each other as a collective to think of how we can use our power to do something differently. And so why is this important to global health? Well, there's a risk of recreating the power imbalances to create and contribute to harmful discourses. For example, the perceptions that we may have of marginalized communities, we can challenge those dominant perceptions, especially if you're part of a group that is considered to have more power. If you're a group that has traditionally benefited from systems of oppression, you can use your voice, your powerful position, to challenge those discourses and these systems to make it more equitable for communities that have been historically marginalized by societies.